Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from ApneMed, Inc.
Hello, I'm Naomi Shaw, Professor of Medicine, Critical Care, Pulmonary, and Sleep Medicine at Icahn School of Medicine at Mount Sinai, New York. Welcome to this program titled Waking Up to OSA, Addressing Barriers to Care and Encouraging Clinical Action. Joining me today is Dr. Vikas Jain, Sleep Medicine Specialist at the Dream Center for Sleep and Circadian Sciences in Frisco, Texas. Welcome, Vikas.
Thanks for having me.
Over the next half hour or so, we'll talk about the burden of sleep apnea, obstructive sleep apnea that is, why it should be a priority for screening, why it's often overlooked in practice, and how to shorten the diagnostic journey for our patients. But first, let's hear from a patient living with obstructive sleep apnea.
I'm struggling, thinking right now. That's what it does to me. You see, I'm gonna get teary-eyed. It really affects me. I used to be able to have conversations with somebody and talk in front. My old job, I used to do contracts and speak in front of a board, a room full of doctors. I used to speak with the VA, the veterans, and speak about for work. Now I can't even speak. And somebody asked me a question, I have to really think about what you just said for me to be able to say it. And before sleep apnea, before being diagnosed, I didn't have this problem. And I think I've struggled with sleep apnea for a while, and it's just gotten worse over the years because I was not getting treated for it. I've missed out on so much. I missed out on my children, not being that mom that they needed. I wanted to go to bed and wanted to sleep, so their father gave them their baths. I was in different treatment centers because doctors thought I had a mental health issue when really it was the sleep apnea, the obstructive sleep apnea. If I would have been treated for that 10 years ago, I possibly would still be married to my children's father, but I didn't know. And so when I would get overwhelmed and lose control of my thoughts and my mind, I just would run away from people. I didn't want to be around anybody, so I pulled myself and isolated myself and lost interest with everybody. And I thought I could just do it by myself, and I wanted to be by myself. So I've lost memories. I've lost time with my children, and I went a divorce. That I did that. And I feel like if I was in a better space and if I would have had treatment for sleep apnea, for obstructive sleep apnea, I feel like that possibly I would have not missed out on any of that. So I missed out on a lot of time with my children. They just kept giving me mental health meds for depression and anxiety, ADHD, all those things. And for 10 years, I was on those. And I kept having really bad headaches. My words weren't coming out. I had tingling in my hands and my legs. I just felt like this weird out of body, like my mind wasn't getting enough oxygen. That's what I felt like before I even knew that I could possibly have obstructive sleep apnea. So I went to the ER for really bad headaches. They didn't do anything about it. They just kind of pushed me off also. Then finally I was referred to go to a neurologist. And she was like, we went in there, we spoke, I told her what was all going on. And she goes, you need a sleep study. And that's when I got my sleep study done. The sleep center called me and told me that I had sleep apnea, obstructive sleep apnea, and that they wanted me to come in. And so I went in and I spoke with them to do a treatment plan for what I was gonna need. And that's when they introduced me to CPAP. They told me that I was gonna need CPAP therapy. And at that moment, I had no idea what they were talking about. I was just like, okay, what does that mean? And then she told me that I needed, and she explained what the CPAP does, and I thought, my first thought was, one, I was excited because I finally got answers. I knew I wasn't just losing my mind, that I wasn't, crazy, that something was actually wrong. And so they told me about the CPAP, that I was gonna need that, and then I didn't want to use it because I had to use it for my entire life right now. And the thought of me having to sleep with this machine forever scared me. So I put it off for the first 6 months. I didn't use it. I just let it sit in the box on my nightstand for 6 months. But then the headaches were still there and my body wasn't feeling good. So I finally thought, okay, I'm gonna give this a try. So then I got compliant and I started using my CPAP machine. And I can tell a difference now. I don't have my meltdowns anymore. I don't lay in the floor crying because my clothes don't fit me anymore. Now, if I don't use it one night, then the next day, all these symptoms come right back. I have these little episodes again. I'm me again. I'm Sarah again. I love to go out on the boat. I love to be outside, take walks. I want to get out of the house, go to the grocery store. It was simple little tasks like that I dreaded. And now the headaches are gone. I don't wake up with headaches every morning. I get up at 5 a.m. instead of 10 a.m. I want to be out with people. I want to socialize and talk. And I'm more in the moment with my children now. I want to do things with them. I'm there for them more than I was a long time ago.
So after watching that video, because now that we've sort of heard from Sarah, tell us about the burden of obstructive sleep apnea.
Absolutely. Yeah, Sarah's story is one I hear some version of almost every week. Obstructive sleep apnea is a sleep-related breathing disorder. So during sleep, our upper airway either partially or completely closes. And that happens over and over again. So airflow drops or stops entirely for at least 10 seconds at a time. And each of these events is associated with either an arousal from sleep or a fall in blood oxygen saturation. But that's just the physiology. What the patient actually notices is something different. They come in because of loud, bothersome snoring. They wake up during the night. They're getting up to urinate. Sleep isn't refreshing and they're sleepy during the day. And then there's a whole set of symptoms patients almost never connect to sleep. Kind of what we heard about with Sarah is, patients can experience things like changes in focus, in concentration, in mood. And those are often the ones that brought them to you in the first place. So in the general adult population, we estimate about 5% of women and 14% of men have obstructive sleep apnea. And that number is rising. The 5-year incidence in middle-aged adults runs somewhere between 7 and 11%. But those population averages hide a great deal. We see that in racial and ethnic minority groups, the reported prevalence ranges enormously. There's anywhere from a 5% to 86% prevalence, depending on which population was studied and how. In patients with cardiovascular disease, atrial fibrillation being the classic example, prevalence runs as high as 60%. And in patients with obesity, up to 46% of women and 77% of men may have sleep apnea as well. So here's the practical translation. If you're seeing patients with cardiometabolic disease, you're already seeing patients in your practice with obstructive sleep apnea. Most of them just haven't been diagnosed yet. And so why should OSA be a priority for screening? Well, we know that when obstructive sleep apnea goes untreated, the consequences reach into essentially every organ system. So neurologically, it can impair cognition, can contribute to anxiety and depression. On the cerebrovascular, cardiovascular, and respiratory front, We see things like stroke, hypertension, heart failure, and there's significant overlap with both COPD and asthma. And then metabolically, we see that it can contribute to obesity, type 2 diabetes, and reflux as well. And then often there can be genitourinary consequences that patients very rarely volunteer, issues like erectile dysfunction, decreased libido, nocturia, chronic kidney disease. But the point I probably most want a primary care audience to take from is this last one, is that OSA doesn't just create new problems, it makes the problems your patients already have harder to control. So the patient whose blood pressure won't come down on 3 agents, the patient whose A1C won't budge, the patient who keeps going back into AFib after a successful ablation, untreated sleep apnea may very well be why. And so beyond the medical comorbidities, there's the day-to-day toll. And honestly, this is probably what patients care most about. So a systematic review of untreated adults found impairment across the full range of health-related quality of life domains: physical functioning, vitality, general health, pain, emotional problems, and mental health. So it's not just a subtle effect, it shows up on standard instruments consistently. There's also driving. We see that untreated OSA meaningfully increases the risk of motor vehicle accidents. And it's not just an abstraction for a commercial driver or for a parent doing a school run. There's an immediate safety issue that we all need to be aware of as well. When Sarah talked about moving through her own life at half speed, really these are the data that we're measuring when she's talking about those things. So it's worth being precise about causality because genuinely it runs in both directions. We see that OSA drives comorbid disease through several mechanisms. There's anatomic and neural effects, sympathetic excitation, systemic inflammation, and fluid retention and redistribution. And that last one's generally underappreciated. Fluid shifting rostrally overnight can narrow the airway further, and that can often make apnea worse as well. And so does treatment actually change outcomes? The randomized trial data has been mixed, and adherence is largely a big part of why, but the large real-world cohorts are quite consistent. There's a study of nearly 900,000 Medicare beneficiaries with sleep apnea, and positive airway therapy was associated with lower all-cause mortality and fewer major adverse cardiovascular events. There's also a Catalonian cohort in Spain of about 14,500 patients, which showed continued CPAP use was associated with a 41% reduction in all-cause mortality, 39% reduction in cardiovascular deaths, a 16% reduction in major cardiovascular events, and a 13% reduction in cardiovascular hospitalization. These are observational data, so healthy adherer bias is a legitimate consideration, but the effect sizes are large and they're reproducing across different health systems and different populations. So the corollary is that does the benefit depend on staying on therapy? What we see from a French nationwide database was that patients who terminated CPAP use had higher all-cause mortality. The hazard ratio for continuing therapy was 0.61 compared with discontinuing it. And so I think this reframes the whole adherence conversation, because adherence isn't just a compliance metric that we're chasing because a DME company needs a download report. It's actually the mechanism of the benefit. A patient who stops therapy drifts back towards their untreated risk. And I say that to patients in exactly those words when they come to see me. So I want to take a minute here to just discuss a bit on how we measure severity, because I think that's where the field is genuinely shifting. So traditionally, we've used the apnea-hypopnea index, which is the number of respiratory events per hour of sleep that are associated with either an oxygen desaturation or an arousal. It's the number that we've built our entire diagnostic framework and really our entire reimbursement framework around. And it's also a fairly poor predictor of who's actually going to suffer consequences and who's going to actually improve with treatment. 2 patients can walk in with the same AHI and really have 2 completely different trajectories. So one reason is that the index counts events without really weighting them. A 10-second event with a 2% desaturation and a 60-second event with a 15% desaturation count exactly the same. But patients differ enormously in their ventilatory deficits and how they respond to it. And that's where the AHI is really blind to all of that. And so that's really the thinking behind hypoxic burden. So the idea is, can we characterize nocturnal hypoxia itself? Can we look at how deep the desaturations go, how long they last, and then rather than simply counting events? So there's several different definitions in use. There's index-based measures like the ODI or the oxygen desaturation index, which is essentially a rate. There's also time-based measures of how much the night is spent below a given saturation threshold. And then there's area-based measures where we're capturing both the depth and duration of these desaturation events. All of these rely on pulse oximetry captured during the polysomnogram. And this is the data we're already collecting on every patient. We just haven't been using it. So the honest caveat to hypoxic burden is that we still need more work defining what normal is versus abnormal, and the thresholds aren't quite settled yet. But for identifying patients who are truly at risk, this may be the more physiologically meaningful index to look at than AHI alone. Even with all of this information, prevalence, comorbidity burden, outcome data, we still see that OSA is still routinely overlooked. And so, Dr. Shaw, can you tell us a bit more about why that is?
Yeah, absolutely, Vikas, and thank you for that really great overview. As we sort of think about obstructive sleep apnea and the metrics that you sort of defined, which is the apnea-hypopnea index, a lot of patients that are not aware of their symptoms and haven't tied it to a diagnosis are just not aware that they may have underlying sleep apnea. So really about 80% of individuals with moderate to severe obstructive sleep apnea remain undiagnosed. It is associated with poor sleep, thinking the exhaustion that we sort of heard about, and many patients don't have the classic symptoms of sleepiness, but they will report things like fatigue, being forgetful, or problems with focus or concentration. And I think there is a lot of variation in how obstructive sleep apnea presents. It also needs to be emphasized that obstructive sleep apnea is sort of in the background of underlying potentially poor lifestyle and sleep health behaviors, right? So an individual who may be exhausted or may be fatigued, but is only sleeping 5 hours, it's really hard for us as clinicians to not take that into account. So it's not always that obstructive sleep apnea is the cause of fatigue or sleepiness. There are other factors which you and I are often teasing apart. The challenges, again, as I just mentioned, one of them is that there are other factors, lifestyle and behavioral factors. Obstructive sleep apnea, often one of many comorbidities, and a lot of the comorbidities are treated with drugs that can also make people fatigued and tired. There are a lot of nonspecific symptoms that we talked about, right? So I often ask patients to distinguish between being fatigued versus drowsy. And drowsiness is something that we certainly know can be treated with obstructive sleep apnea therapies, but being fatigued can come from many different reasons. Heterogeneity in presentation, differences in snoring tolerance, especially if they're sleeping alone versus a bed partner. Healthcare access is a big one. Primary care physicians have limited amount of time, and how often are they really trying to tease apart symptoms from obstructive sleep apnea or poor sleep related habits and other comorbidities. So there's also the patient hesitation to be tested because they don't want to use CPAP, but also they don't want to come in and spend a night in the sleep lab. So that's also another barrier and challenge. So how can we really shorten the journey to diagnosing obstructive sleep apnea? Maybe this is where both of us can talk about really knowing the risk factors for sleep apnea. So are there specific risk factors, Vikas, that you're looking for that automatically tell you this person needs to potentially have a sleep study versus those where you may look for behavioral factors?
Yeah, for me, I was primary care trained and then went into sleep medicine. And so the approach I've often taken when I talk to my primary care colleagues is to stop looking at these as separate risk factors. We see that the prevalence of OSA is high in treatment-resistant hypertension, in diabetes, with obesity. And oftentimes we have a patient who's not carrying just one of these conditions. They're carrying 2 or 3 of these or more. So when I start to see that these risk factors cluster, if I see at least 2 or more of these risk factors, I've stopped asking whether to even screen for sleep apnea. It's more just how quickly can I get this patient tested? And I think that's been a helpful tool sometimes for our primary care colleagues as well, to look at this and say, hey, you're showing more than one risk factor. You should really get screened and tested for sleep apnea.
Yeah, that's really well said. I completely agree. I think there's so many of them here, including obesity, which now is really targetable with drug therapies. And so that's a big one. I agree with you. Treatment resistant hypertension is a big one. Congestive heart failure and atrial fibrillation are really two important ones that patients do actually have not just obstructive sleep apnea, but central sleep apnea and congestive heart failure. And atrial fibrillation, same thing applies. So I think you're absolutely right that it's important to keep these in mind, but sometimes our goal is just to expedite and get them tested. And then in terms of non-traditional risk factors that are associated with higher risk of obstructive sleep apnea, there's obviously patients that are listed on the slide that we may not always think about, right? Which includes individuals from different parts of the world that may have a lower BMI, but may still be at risk for obstructive sleep apnea. And then patients from urology with nocturia, which we know can be a manifestation of obstructive sleep apnea and responds beautifully to some therapies. And then patients with glaucoma and floppy eyelid syndrome, again, are sort of some of the non-traditional risk factors. I don't know if there's anything else that you would add for folks to be able to look for these non-traditional risk factors.
From here, I mean, I think a few points. One, it's very common, I would say, for us as sleep specialists to hear about patients getting up multiple times at night to use the restroom. And it's just my prostate, doc, is what I hear a lot of. And then the other, I think, important point on this slide is really not to just focus on BMI. I always like to tell my patients that when we look at the data in obstructive sleep apnea, 50% of patients may be overweight. That means the other 50% are not, right? And so we do see that for certain populations, especially Asian populations, lower BMIs can still carry a higher prevalence of sleep apnea. So don't let a low BMI, dissuade you from looking for a condition if patients have other symptoms of this condition.
That's really well said. And in terms of the symptoms, right, one of the things that I find challenging is, I don't know if you've had this situation where people come in with unrefreshing sleep or they feel fatigued, and then you do a sleep study, even if it's a full night sleep study, data doesn't always describe what the patient is telling us. I don't know if that's happened to you, but I often find that that's when I'm the most perplexed, right? Meaning their sleep study actually looks really good, but then their symptoms do not reconcile. And I think that's really where I would encourage folks to dig deeper. There may be other things, the ICSD has like 100+ diagnoses, and it's not always obstructive sleep apnea. So it's just something to keep in mind when we're looking at some of the non-traditional risk factors, but also non-traditional symptoms in patients where you think it's obstructive sleep apnea. So really know the symptoms, right? And I don't know if you look for any others, but snoring is a big one. Excessive daytime sleepiness is a big one that patients come in with. Tiredness and fatigue is often one that is harder to tease apart, but they do come in with that quite often. I've seen a lot of that in the post-COVID era. I don't know if that resonates with you, where a lot more patients are coming in with fatigue, but it's sort of hard to tease that apart.
But I think knowing both the symptoms and the risk factors is very helpful, right? I mean, why do patients come to see us? I would say most of my patients don't come because of their snoring. They come because their bed partner has said, I've had enough of your snoring, right? And so if we only screened the patients who volunteered themselves that they're tired, we'd probably miss a lot of patients. So really, if you're starting to think about it, ask, like, are you getting up a few times to use the restroom? Do you wake up in the middle of the night? Do you feel tired and fatigued throughout the day? Sometimes patients don't think of feeling tired or fatigued the same way we think of sleepiness. And so sometimes teasing that out can be helpful. And if they start to give you, I'm starting to hear a few things that are making me concerned about this condition, that's where I can help guide patients on why they're coming in to be tested.
Yeah, but certainly snoring and sleepiness are the top two for me. And I agree with you. It's not always the patient. A lot of times it's the bed partner. And then in terms of treating sleep as an important aspect of health, I sort of touched on that. I don't know if you want to elaborate.
I always tell patients we spend a third of our lives asleep, right? If it served no purpose, it would have been a big evolutionary mistake, right? So clearly it serves a vital function. That's a very, very important aspect of our health. Really, we want to treat sleep like it's a vital sign, right? So we want to make sure that we're asking patients about their sleep at every visit, the same way we ask about smoking. And if that patient's bed partner is there, I'm usually more directing the questions at them because they're usually the ones saying yes, 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 where we kind of often can see patients systematically underreporting sometimes their own symptoms as well.
true. Very true. Yeah, I completely agree with that. And, one of the things I often tell patients, in addition to what you said about a third of your life is spent sleeping, is that, we can't fix everything by fixing obstructive sleep apnea, right? I can give you no drugs or CPAP that is going to fix the fact that you sleep less than 5 hours per night on average. I can't do that. It doesn't matter if you wear CPAP the whole night, right? So sleep is critical aspect of optimal health. A lot happens when we sleep. It's not a passive state. There is a lot of active work that organs, including the brain and the cardiovascular system, are actually experiencing as a result of sleep, which is extremely beneficial to human health. And I think that that is an important aspect that we certainly cannot overlook. And I think the slide is essentially emphasizing it. So, yeah, this is a great discussion. Let me sort of turn to a couple of questions here. So, I think 2 questions can be highly predictive. Do you snore loudly every night? And has your bed partner witnessed apneas? I don't know if you ask these questions every single time, or how do you approach these 2 specific questions?
Yeah, I would say in our practice, it's on our traditional patient questionnaire. Do you snore? Have you ever gasped or choked? Do you have any witnessed reductions in your breathing at night? And often we encourage patients, if they do have a bed partner, to ask their bed partner about their observations. Because I would say that's also pretty typical. I'll have a patient who says that they don't snore, but their bed partner is no, they clearly do. So it's very helpful to have that in there. And then again, as sleep conditions, obviously we have our smart phrases, but it can be helpful to have a few questions prepared as an EMR smart phrase. Sometimes that helps primary care colleagues quickly pull up a few questions to prompt the patient.
Yeah, absolutely. A lot of us were using these templates and smart phrases. And I think the challenge is that you run out of time for patient visits, right? And so really getting all of this done, including getting an obstructive sleep apnea history, their sleep history, and talking about the diagnostic pathways is sometimes challenging. It's really where you can use tools like smart phrases to help remind you and also keep you on track using templates that you don't forget. So screening tools and questionnaires, and specifically stop bang. I think stop bang is one that's very commonly used in a lot of clinical settings, but also in research studies. And it's essentially these 8 questions that a patient is answering. It's talking about snoring, questions about being tired, whether anyone has observed the patient from stopping breathing during sleep, and whether the patient has or is being treated for high blood pressure. And then there's questions around measurements that we would get from patients, including their BMI, which is not always perfect, but it helps sort of guide potential risk for sleep apnea. Age is another one where increasing age is really associated with increasing sleep apnea risk. And then it sort of plateaus after a certain age, like 65 and above. And neck circumference is a big one. I'm not measuring it in every sleep patient. And then, being male, gender also increases risk. So this is a tool that is used. Do I use it in my clinical practice? No. I'd be interested to hear if you're giving a stop bang to every patient that's coming into your sleep practice.
So I'm not, but what I love about the stop bang is that if you answer yes to 3 or more questions, there's a high risk of OSA. And 5 of these 8 questions don't require asking a question, right? You can just assess, is your patient male? Are they over 50? Are they being treated for high blood pressure? Like, as we said, primary care doctors, we don't have a lot of time with our patients. How can we help kind of speed this up? So sometimes whether you use the tool for its intended purpose, or if you understand what it's really asking, it might really help you identify patients that are worth screening.
Yeah. And to that point, just to provide a slightly different angle, I tell my patients that if I were to take 10 people walking outside our clinic, and if you just took the fact that they were greater than 50, they're male gender, and I don't know if they look tired, that's a lot of people, right? So I think the problem with some of these tools that I have personally in my practice is it may be capturing more than just the disease itself, right? And so when the prevalence of something is as high as what we are saying, I wonder if truly it's a disease, or maybe there is an in-between, and there may be some potential pockets where we're picking up what we're calling obstructive sleep apnea, but maybe it isn't. And so I think that's why screening tools are great, as you mentioned, in primary care practice, but by the time they hit our door as sleep physicians, a lot of this, unfortunately, is not really usable. And then we talk about the Upward Sleepiness Scale, which I do use in my practice a lot. Actually, every patient gets it, and it is imperfect, especially questions around driving are really not as applicable in New York City. So my patients are always, what do I do with this? Dr. Shah, how do I respond to this? But it gives me a general sense. And these are the questions, right? So what is your chance of dozing off or falling asleep in each of these situations? You give a score from 0 to 3. If the total is more than 10, I'm thinking, okay, there's some objective sleepiness here. But again, I haven't teased that apart from it being from the fact that they sleep 5 hours versus an AHI that's 10. And that's always something I'm constantly doing in my clinical practice. The Berlin questionnaire is another one which has been around forever and is used a lot in research studies. I'm not personally using it, but it's essentially looking at these symptom categories: frequency of snoring and apneas, daytime sleepiness, and blood pressure and body mass index. And a high risk is if you are positive in 2 or more categories. It's another tool, again, more applicable in the primary care setting, but not really in the clinical sleep study population or referral practice. So other screening tools and strategies, let's talk a little bit about what you're doing with patients who are coming in with wearables and smartwatches. And I can tell you what I'm doing. It's really hard. They show you data from Fitbits and Apple Watches and things like that. I'm using it as a guide, but not necessarily as a screening tool. So if there's a lot of disrupted sleep, for example, or if the patient is clearly demonstrating that they're sleeping 10, 12 hours a day, that again is an indication that something is going on. It's never a primarily sort of diagnostic tool. I don't know if you're doing anything differently.
No, I would agree. I mean, very similar. I always like to make sure patients understand that some of these wearables may have FDA clearance for notification, but a notification doesn't mean a diagnosis. Diagnosis still requires a sleep study. But where I do like patients using this is more of a big picture, like you said, like how many nights a week are you getting 5 hours, and how many nights a week are you getting 7 plus? How consistent are you with your sleep? How variable is your sleep schedule? How much social jet lag are you experiencing on the weekends? Those things are things that oftentimes we're not really paying attention to day to day, but they can definitely be contributing to daytime fatigue and sleepiness as well.
Yeah, thank you. That's well said. So in terms of the diagnostic tools, this is really the gold standard, which is a lab-based polysomnography. This is where a patient typically comes into the sleep lab. You get EEG, which is brain activity, oxygen saturation, airflow, and then abdominal and thoracic movement. And we take all of this and we combine it and we deliver on the apnea-hypopnea index, which is a metric that takes all of the pauses in breathing, complete or partial, including associating it with the arousal on the top, or if there's a desaturation or both. And we basically give a ton of different metrics that really confuses people and is kind of good because we can help our patients when they see the report, which is quite long. So it's really the gold standard. Is it used all the time now as sort of the first stop? No, because we have other ways to do this in the home setting, but it certainly still remains the gold standard when the home sleep testing isn't able to answer the questions. So the advantages of home sleep apnea testing, as I mentioned, the patients love it because they can do it in their home. We all have disposable devices now, and they are also one night use. So it's just very efficient and less costly. Their disadvantages really are that there are a limited number of sensors. So typically you're not getting a lot of activity on their sleep staging, and the EEG is not captured in most of these home sleep apnea testing devices. And if the sensor doesn't work, the patient doesn't know about it. So then you just have to repeat the study. But it's completely transformed how we diagnose sleep apnea, and I think was a really great additional tool. And then CPAP really can't be initiated, obviously, during a home sleep test because nobody's there to give them CPAP. And false negative rates as high as 50% among patients with a high likelihood of having OSA. And in that setting, we would basically escalate to an in-lab sleep study anyway. So if a clinical suspicion for a patient with sleep apnea is high and a home sleep study shows they don't have sleep apnea, we obviously don't stop there. We would bring them in to the full night sleep study, which essentially tells the patient, well, we still think you have it. So we're going to bring you in and confirm. And if it's not there, it's less likely it's there. If we find it in the lab, then we've diagnosed the patient. So there's certainly strong advantages and then some disadvantages of home sleep apnea testing. In terms of referrals and co-management, clinicians obviously can screen, diagnose, manage straightforward cases, and then refer the complicated ones to sleep specialists. I mean, I see a mixture of both. A lot of them are the complicated referrals, sometimes for second, third, fourth opinions. I practice in Manhattan, so that's just what we have because we have a lot of sleep clinics around. But what has your experience been, Vikas?
Yeah, I would say we see a bit of both. I mean, clearly there's some simple patients we see that even I think primary care physicians could have screened and tested for as well. We also do get second, third opinions. I see a lot of other more rare sleep disorders as well in my practice. So really, I think the ask is to start to diagnose and screen using home testing in your offices. And then where you see patients who struggle like with CPAP, or if they can't use the treatment, or if they're looking at alternative therapies, or if they want to understand more of the nuance of some of these alternative treatment pathways, that's where getting your sleep specialist involved can be very helpful.
Yeah, it really depends on capacity of those that are referring. If they're able to do the primary stuff, they can, and then they manage it. But oftentimes we get referrals for just the diagnostic piece, even if it's the home sleep test. It really depends on that. In terms of the reimbursement codes, they're listed here. You can refer to the American Academy of Sleep Medicine page on sleep medicine codes, the CPT codes for sleep services like polysomnography, which is the in-lab sleep studies, are listed, and then the HSAT, which is the home sleep apnea testing codes, are listed. Is there anything you wanted to add to this, Vikas?
Only other add would be that some of these codes, I know we're having some changes upcoming to some of the home sleep apnea testing codes for 2027. But generally, yes, most of our codes rely on either in-lab coding or home sleep testing codes in terms of what we use.
Yeah, that's great. So before we close, I'd like to highlight some key points. OSA has a significant impact on quality of life and on morbidity and mortality. I think that this is sort of the biggest takeaway, although as you showed the data on cardiovascular outcomes and treatment of sleep apnea, there's a little bit of a disconnect. So I don't know if you want to talk about how you're viewing that observational data supporting that sleep apnea is a risk factor for mortality and cardiovascular outcomes.
I mean, I'm interested to get your opinion as well. My opinion on that, when I've looked back at the data, is that really the benefit is with staying on therapy and using therapy for the full duration of the night, right? I don't think it's enough to say we diagnosed you with sleep apnea and someone gave you a CPAP, and that's probably good enough. We want to actually get a sense of, are you actually using it, and not just enough to make your insurance company happy, but you actually using it enough for your health benefits. We want to see you have it on for the duration of the entire night so that we're addressing your sleep apnea for that full duration. And when we go back and look at some of these studies, that's where we see patients who don't use their CPAP, if they're only using it for 3 hours, they're largely not getting that cardiovascular benefit. And even with the French cohort that we discussed, taking away the machine means that the risk starts to return. So it is important to not only diagnose your patients, but making sure you're keeping an eye on them year over year and making sure, are they actually being adherent to the therapy that they're supposed to use.
Yeah, so in terms of key take-home points, for me, the key take-home points are really, number one, everything isn't obstructive sleep apnea. So if you see a patient that's sleepy, really think about other things that may also be contributing to their sleepiness or fatigue. Number two is obstructive sleep apnea in symptomatic patients is very different than obstructive sleep apnea in asymptomatic patients. So just because you get an apnea-hypopnea index that is 15, but if the patient is sleeping 8 hours, feels great, has no complaints about their sleep, forcing a diagnosis and treatment may not be the best approach, and sort of vice versa. Having a symptomatic patient that is clearly sleepy but has very mild sleep apnea still may benefit from treatment of sleep apnea, because again, there is this disconnect between how severe someone's sleep apnea is or how mild it is and how their symptoms may manifest. And so I think, to me, those are the biggest take-home points. Vikas, did you want to add any to those?
Yeah, I would say, just from what we've discussed, one big take-home point, these patients are sitting in your clinics every day, right? It's not that we're asking you to go out and try to find them. They're literally walking in with a lot of these risk factors already. I think also, as you alluded to, AHI is just the starting point. It's just a number. It's not the whole picture. I always like to use that kind of twofold. Sometimes patients can have mild sleep apnea, but a very severe REM AHI, right?
Oh, wonderful. So, Vikas, thank you for this great discussion. I think we really were able to cover a lot of symptomatology of sleep apnea and the testing and the risk factors and consequences of obstructive sleep apnea. And I want to thank you all for participating in this activity. Please continue on to answer the questions that follow, and also please complete the evaluation.